difficult. You can go back and review it. So thank you all for being here. And more important, thank you for all that you do every day to make a difference in everyone's lives, including your own. So I'm going to listen in for a little while. If you have immediate questions. Otherwise, great that you're all here tonight.
Thanks, Marv. All right, so I'm very happy to present Lisa, who, like I said, is an EMT out of District 14. She and I talked a few months back about documentation, and she said, yep, I can talk about this and teach us some new things as well. And we'll talk a little bit about quality assurance after she's done. And of course, if you've got any kind of questions you want to ask, you can put them in the chat and we'll get to them toward the end. So Lisa, again, thank you very much for joining us. And the floor is yours.
All right, thanks for having me on. Yeah, I've been a firefighter EMT with District 14 for going on 5 years now. And then I just recently started helping out with the data entry for NFIRS and then helping people with their report writing over the last year. I'm not a legal expert. I just try to help out in ways like spell check, things like that. There's, lots of little things that people can work on, making sure everything's billable, that we can send things off to insurance and not have any legal issues, of course. Obviously, our departments have gone over this, hopefully a few times in your careers, and also EMS Connect recently had a module on this. If everyone's up to speed on that, that's a helpful one. It covers a lot more of the legal aspects. This is kind of more general things that are applicable to our county more. Sounds like after 2022, there were kind of some red flags coming into the new year. So part of this BLS Focus Training, we want to get on the same page with documentation. We'll go over some of those specifics a little bit later. But since Dr. Wayne is here, I was wondering if he wanted to mention anything that he's seen on his end that's specific regarding big issues with report writing.
I think the most important thing on report writing, a lot of it's boxes and a lot of it's electronics, but it's a narrative. What you saw, what did you perceive based on vital signs, which are vital, and what did you do? And then where did you go and how did you transport? So let me give you a very short example. Sometimes patients change en route, and sometime in the last month, we had a case of a patient that looked pretty good in transport, got transported BLS because of the characteristics in the field, which was very appropriate. But during the transport, the patient's condition changed, and by the time the patient reached the hospital, there'd been a radical change. And that EMT had to make specific notification to the ED staff of what happened and what the change was, so that the staff refocused their particular response to the current needs, not the pre-perceived needs of the patient. When you do that in a thoughtful and processed way, and you document the same way. So just again, say somewhat, what did I do? Why did I do it? And what was the outcome, or what was the process? And then you've not only done a great job of documentation, you've allowed yourself to go back and assess what you did and where your strengths and weaknesses might be. Because again, all of this is team sport. It's not one person does everything or one person knows everything. And with that, thank you.
Great, thank you. And before we really jump into this, just wanted to say thanks everyone for being here. It's a nice sunny Thursday, so we'll try to keep it brief and stick to the points here. The big purposes of documentation, obviously quality control. We want to collect data for the county, look for areas of improvement. We can track results of procedures used, effects of medications that people are giving. We can take statistics for example, opioid use or other national health crises that may be occurring. It's a good way to track those things. It's also a legal record. As mentioned, it's important for everyone to record what they did, everything that they did, in case, 5-10 years down the road, something comes up. You're not going to remember anything, but your patient care report should have everything in it that happened so that you don't have to remember anything. And then of course, it's a medical record. It's obviously becoming more and more that these records are accessible to people since they are electronic. A lot of, doctors' offices have portals where patients can access their medical records basically instantly as, the doctor is scribing their notes. So we have to think about that coming our way also down the road. So as soon as your patient care report is done, it can be seen by the hospital staff. It can be seen by insurance when those get sent off. And then we can imagine that eventually our patients will be able to see them very quickly. So it's important to think about the eyes that'll be on our reports as we write them. And then of course, insurance billing, that's where we get a lot of our money from. It's going to be through sending off these reports, getting them billed, and then getting paid. So everything we do is within those CMS guidelines, because the Medicare system kind of dictates how all of their insurances go when it comes to their requirements for transport. So obviously we're all familiar with image trend. I'm not going to get into the specifics of image trend on this, just because that's kind of department specific on how they want you to use it. But we'll talk about just some specific things that you should be doing, and then some things to avoid, and some brief stuff on using image trend, and then some legal things. And that'll be it for the evening. Obviously, things we should be doing should be always documenting patient contacts. So this is even the briefest contact. You're going to be wanting to form up a PCR. You want to put in all the information you get, even if it's just a little bit, and then obviously explain why you didn't get certain information. You can put in all the pertinent negatives, like the patient was, combative. The patient was running away from us and didn't want to tell us any information. You need to let people know, let it be put in the record why you didn't get certain information, even if it's just a little bit. You can document what you have and then document why you didn't get the rest. And that should be for every patient contact. So no matter how small it seems, if it's not generated, then it's not there and it never happened. And it's going to be your word against their word. And then of course, following our protocols. I don't know, Steve, if you have any specific protocols that you can think of that are commonly missed, or things that people need to focus on, especially with the recent changes.
Yeah, Lisa, how about we just said after your presentation? Thank you for that question. It's a great question, but how about we address it after? Thanks.
All right. So obviously everything I'm going to say, follow your protocols. If you have questions about those protocols, you can send those in as a message as well. And then Steve, if you want to think of some of those common protocols, we'll go over those after. You're going to want to document all your procedures, all your medications used. That includes, I think, just one common example I can think of that people forget is when you give someone oxygen, you need to add a procedure for the way you administered it. So whether that's a non-rebreather or a nasal cannula, you're going to want to say that you gave them oxygen as a medication, and then also as a procedure, putting that nasal cannula or however it was applied. So it needs to be complete in that way. A lot of medications come with like a route of administration, so you want to document both of those. Another thing we need to remember to do is check your timeline on image trend. So there's lots of little nuances within that. A lot of times I see people saying that the patient arrived at the destination and then recording, 10 minutes later that they took vitals, which is not something that would happen in a normal situation. So you just need to check that, make sure everything lines up from arriving at the patient, what you did, and then it's kind of a comprehensive overview. It's something you can really use as a tool to make sure you got everything that you did. Looking at that timeline, seeing everything kind of in a list view can be really helpful in kind of getting everything in line for yourself to look at and make sure you didn't forget anything from vitals, exams, and also those procedures and medications. And another thing that sometimes gets missed is people put everything down within the same minute. So they arrived at the patient, let's say at 19:20, and then they said they did their vitals, their exam, they administered oxygen, and they got a patient signature all within that 1 minute. It's all at 19:20, and that it's kind of a red flag for insurances. Obviously, that's not possible. It kind of makes you less credible when you forget things like that. Same goes for grammar and spelling. If you're getting yelled at by a lawyer in court, they're going to be saying, if you can't spell the word, vomiting, you probably aren't the smartest EMTs, so you should be checking your spelling on all your reports. It's easy to use softwares, obviously, to do that. Same with grammar. It just makes you more credible, makes you seem like a professional rather than someone who can't spell simple words. It's a really easy thing to look at and check over for a few minutes after you're done your report. Make sure all your spelling is there and your grammar. Another thing you can include in your report is going to be attaching images. So if you're on an MVA, you can take pictures of vehicles. You can take pictures if you needed to get a paper signature for some reason. If you have face shoots in the hospital, all that stuff adds information also for insurance billers and for a record down the road, just that you have all that stuff. It's pretty easy to attach things on Image Trend. If anyone has any questions about the features of Image Trend that I bring up, feel free to also put those in the messages. We can look at those after. And then one other thing we can do to help out our paramedic friends is do our ALS transfers. So even if they don't necessarily see the patient, a lot of times it can be helpful for them if we send them our reports. Also a simple feature to use, something that we need to just do. And also if we transfer the patient to the paramedics, we can do that transfer to them with a complete report. That way they know what we had even before they got there, and we can pass that on to them. Some things to avoid in your reports. You don't want to give too much of your opinion. Obviously, you want to state what clearly happened. You want to tell a good story, but we don't want to include too much about what we think was going on if it wasn't obvious. You don't need to make things up. You don't need to embellish things. Just tell what happened, tell a good story, and don't add your opinion or things that are not necessary. And then an important thing that insurance also wants to see is that we include signatures from our patients. Obviously, the preferred choice is that we get a signature directly from the patient. Of course, there's situations where we can't do this. And then the next best thing to do is to get a signature from either a patient representative or the hospital from one of the personnel there. And basically, we're at a point where if there's no signature from one of those three groups of people, the report cannot be billed because there's no reason to not get at least one of those signatures. So those are those options. And obviously, if there is some sort of equipment failure with your technology, you can always use like a paper signature sheet. Your department shall have those as well, just in case. When it comes to patient refusals, that's kind of another big thing that's been going on that really needs to be focused on by our departments, by our EMTs. First of all, there's not really such thing as leaving someone home per protocol when there's anything abnormal going on. So if someone calls 911, they're having a problem. If they have any sort of abnormal vital sign, there's not really a protocol for us to leave them at home. We are a transport service. We don't get to tell people that they don't need to go to the hospital if they want to go, basically. Very few exceptions to that. There's obviously times when people just need some education, but there was a recent incident in the county where someone got left at home, and the next morning they had to call EMS to come back because they had a broken femur, and they had been put back to bed at 2 a.m. and given some Tylenol, told they were fine. They got a refusal from the patient, but the patient didn't realize what they were signing was a refusal, and ended up waking up in the morning with excruciating pain, unable to move, sort of thing. So people like that shouldn't be left at home. If someone is on blood thinners, obviously, especially an older age person, any sort of trauma, that should be a transport. And people should understand what they're doing when they're refusing, and you should document that. Anyone who's altered, anyone who is having some sort of mental status change, those people can't refuse transport. So we can't have any sort of excuse for leaving people at home, especially when they're having any sort of medical issue. We obviously can't see a lot of what's going on. So they need a higher level of care. And if you are going to have a patient who doesn't want to go to the hospital, those refusals need to be documented very thoroughly. Those are the type of people who call back later and have a bigger issue going on. And then you need to obviously have documented why they didn't want to go in the first time for insurance and also for legal record. Don't want to get into trouble there. That's what it for things to avoid. So don't give your opinion, and then make sure you're not missing any signatures. And when it comes to image trend, obviously we kind of mentioned a few of these things. Use your power tools, if everyone's familiar with that. There's lots of good buttons to use. You can use the medications, the procedures, and then there's also some situations like, for example, cardiac arrest will give you a list of things to remember to document when you're doing your exams and your vitals. Make sure you're being thorough, make sure you're including everything. There's lots of things you can add in there. And then most importantly, you're going to compile everything in your narrative. So whether or not there's the right power tool for what you did, you can definitely write it down, put it in your narrative, because that's going to be kind of the big bulk of where your documentation occurs and the things that are going to come up down the road. As long as it's in your narrative, that kind of catches everything. And then there is a nice option on image trend if you ever want to see kind of what the hospital sees or what other people see when it comes to your patient care report. You can view your PCR as a PDF, and it kind of compiles everything into one big document where you can just go through and look at it, make sure all your blanks are filled in, make sure all your information's there, and kind of view it as one big picture. So anytime you want to do that, you can just play around with image trend, look for that. It's kind of at the top middle of the screen. It says view as PDF, and you can just go ahead and pull that up. It opens up a new tab, and it's helpful to view your PCR as a PDF. And then lastly, we'll just talk about some legal considerations. Obviously, again, I'm not an expert in any of this legal stuff, but you want to be a credible EMT when it comes to your patient care reports. You want to make sure you have good grammar, spelling, make sure your report is complete, make sure your sentences are complete, don't leave anything unanswered, and be consistent. There's not really any situation, no matter what time of day it is, where you can all of a sudden decide to slack off on your report. It's our job to do a good job at documentation as well, because again, like Dr. Wayne said, if no one's going to know what our job is if we don't document it. No one's going to see what you did if it's not there. So it needs to all be there, be consistent, make sure it's complete.
May I make one comment?
Yep.
On this medical legal issues? If you got to be, sometimes patients say things that can have significant repercussions later on. You come to a scene, maybe where somebody's been injured, damaged, shot, stabbed, who knows what. And, the bystander will say, well, I'm really sorry I shot him. Limit to your participation in listing or limiting, or putting things down to exactly what you in either private or personally hear, not hearsay, or what the patient says. But stay out of, if it's an altercation, assault, shooting, stabbing, law enforcement is going to be there. Okay. But if the patient says, Joe shot me, again, you don't have proof of that. And if you don't, you can't put down patient was allegedly assaulted or shot by another individual who's, who's law enforcement is on the scene or something to that effect. But, again, be careful, because a lot of times things that you say will be dragged into a court of law along with you.
Yeah, and that's obviously where the phrase patient stated and then directly quoting the patient, that's perfectly appropriate to use, because then it's nothing to do with what your opinion is or what you think happened or what you maybe heard, but this is what the patient directly said to me. And again, we're not police, so if there's anything that's up in the air, then ask someone, a superior, for help on what to include in that PCR. You should be able to get help with those if you're not sure of the legal repercussions that are surrounding the call, especially again if it's something criminal, if there's an assault of some kind. And then while these issues won't come up if we do cover all our bases, everyone's heard of tort, negligence, and using your performing your duties, breach of duty, all those things. There's all these examples of situations where people don't do their job or don't include things that they should be including in their documentation. And if we do our job properly, those things won't come up. There won't be any question about whether or not we did our job if we document it properly and we do provide patient care. That's our job as EMS providers, is to help people, not to form opinions, not to give our opinion on situations and to make accusations. It's just going to be all us doing our job. Obviously, it's a community service sort of job. So just to remember that, cover those bases, and then we won't have to deal with any of these legal issues. And then, like I kind of touched on before, any sort of patient refusal needs to be very clearly documented. Also documenting that the patient had adequate mental status, that they weren't in any sort of altered state, that they were not able to refuse transport, and that you did explain to them all the possible risks of using transport.
Holly and Toby, stop.
And then also releasing people per protocol isn't really something we do. There's very few situations where someone who wants to go to the hospital should be denied transport. I really can't think of any situation where we should deny someone transport when they want to go in. And then I guess it's kind of hard to do since this is over Zoom, but just some things that we can think about when it comes to writing our narratives. There's obviously lots of like creativity that you can use, pull up the thesaurus, use better words trying to describe situations. When you're doing your exam, really think about adding in those pertinent negatives. So going through questions, for example, like when it comes to the head portion of the exam, you can ask someone, are they dizzy? Are they having a headache? Has there been any syncope, loss of consciousness? We obviously have plenty of time with our patients. We can really go through a thorough exam with questioning, and then putting in all those pertinent negatives is big. So including the lack of pain in any sort of area, lack of shortness of breath, there's no chest pain, there's no edema, things like that. All those questions we can ask our patients. I think it's helpful just to kind of brainstorm for yourself those big things. You should kind of have a flow when it comes to writing your report. The questions you ask every single patient, just so that you can document that you ask those questions. I have just an exam in my mind that's just every single head to toe part, and you ask, 2 or 3 questions from head to toe about how they're feeling, any pain. You don't necessarily have to expose and examine every patient unless it's a trauma. But you can definitely include lots of questions, get creative, and we have plenty of time with our patients. So use it to do a thorough exam, make sure you get all the information you need, and then that can really help in down the road. If anything comes up, you can say, hey, I checked that. Look, I wrote, it did not happen. And then that's all I've got from my spiel. I was hoping we could get some questions, talk about anything that people have thought of just in this presentation.
I'm gonna go in a sec, but just one thing that I always want to people to remember, is the issue of refusal of care, and that is, we have a responsibility to make every best effort to convince a patient who you truly believe needs to be transported. And sometimes that requires working with the family, and sometimes that requires working with the patient. But there's one fallback that I think everybody's been hesitant to use in the past, and I don't think that's acceptable on the part of the concerned individual, and that's the ED star doc. We have one physician who's on all shifts, who's designated as the star doc. That's the physician who is responsible for EMS calls, referrals from outside physicians, reading the initial read on an EKG that's not done, that may be done in the lobby or on a new patient brought back. And do not hesitate to use the resources of the ED. They might say to you, well, I'm not there. But you can't say, I've got a 56-year-old male who's got hypertension, who's got chest pain. He's a little bit diaphoretic, and he thinks it's just indigestion. And he's really not being cooperative. ALS is a long way out, or we can't get him right away. Sometimes it's even necessary to let the doc talk to the patient. And we are the advocate for that patient. So just remember that, and use whatever resources, whether it's family or whether it's medical, to help you facilitate getting that patient to care. Okay.
Yeah, thank you. That's very important for us to remember too, as we're caring for a patient. Like you said, they have family, they have, they're humans just like us. We can establish a good rapport with our patient, and then using that, we can hopefully convince them that they do need higher medical care when the situation arises. It's definitely a good thing to remember.
Well, Lisa, before we get to some of the questions, thank you very much for an informative and entertaining presentation. And I'm telling you, I took a little bit of notes here. You hit all the great high spots that we wanted to get out to both the medics as well as our EMTs. So great job. We do have one question.
Really nice too, but I'll give all the info needed.
So I have one question in the chat. Alyssa, I see your hand. We'll get you in a second. This is from Christy. Christy says, new user to image trend. How do you go back into a chart and add an addendum? Do you want me to take that, Lisa? Or do you want me to do that?
Yeah, go for it.
All right. So Christy, well, first, welcome to the system. At the bottom of your validation score, you can click menu. You can select to add addendum or attachments, whatever you may want to do. Type your addendum, you'll click OK. It'll be, I think, in a pending mode. If you like it, you go ahead and click OK again, and that'll add it to your EPCR. Hope that answers your question.
Can you still see my screen?
We can. Yes, we can.
Okay. So I just I'm on image trend here, just to show you where that is. It's down on menu. Sorry, now it's changing things. Menu, and then right there you see addendums.
Oh,
and you're
great.
Add new, and then you can go ahead and add that in there. And since we're here, I'll quickly show the PDF version of a report. So you're just hitting PDF, and then there's some options here. They're slightly different. So you can look at the pre-hospital report system design, fully missed part. So just want to see kind of what the, for example, hospital would see if you sent this off to them. Let's see if it loads up here. So when it's complete, it's going to have all this stuff filled in, and then there's going to be a lot more. This is just obviously one where there's no information put in, but it generates a PDF, which can be really helpful to view your full picture of your report. And for example, if this goes to court, they're going to print off this nice PDF and give it to all your lawyers. So.
Yeah. All right. Alyssa, I know you had your hand up. Go ahead and ask your question.
All right, Lisa, thank you so much for your instruction this evening. I just had a question on that last slide. You had a statement that said, show, not tell, and I was hoping you could elaborate on that a little more.
Yeah, for sure. That's one of my favorite phrases from an English teacher back in high school. It's, when you're giving a description for something, you want to show what's going on, not just make statements. So you can say patient was feeling short of breath, or you can say, rather than telling someone that they're short, or saying, I guess it's, you told them this patient is short of breath, or you can show them by saying patient was tripoding, they were pale, they were breathing at a rapid rate, and you could hear audible wheezing. That's showing me what's going on, because now I can close my eyes and picture it. Whereas when you say patient appeared short of breath, I could picture 40 different things that might be that patient. So that's just kind of the phrase I try to think of when I'm writing my reports, that I'm going to try to picture everything that's going on. You're showing it, not just writing statements. Obviously, there's kind of a fine line between showing what's going on and not giving your opinion on, like, oh, this person, looked like they were really having a hard time in their personal life. That's going to be kind of more opinion than it is fact. So there's kind of that fine line, but that's what I was going for with that phrase.
Great, thank you. It's going back to what Dr. Wayne was saying, what did you see? So it's
right.
An explanation.
Yeah, and I think for me, going over reports, I've obviously, I go on calls as well, but if I'm not on the call, it's really, really hard to imagine what's going on. So you can imagine that any sort of lawyer or insurance person, they also have no clue. They've never been on an EMS call. They don't know what they're looking for. All they have is a piece of paper in front of them. So you really want to paint a good picture with that.
Thank you.
Yeah, you're welcome.
great questions. I think we have another question here from JH. I'm sorry, I don't know who you are or know your first name, but JH asked, with the 21st Century Cures Act, are patients able to see their pre-hospital reports the same way they can see all the hospital notes now? That's a really good question. Does everybody know what the Cures Act is? It's I think it was signed in October of 2022. The definition of electronic health information, EHI, this allows both patients and doctors to share information electronically, and they have the right to access any of it. So I assume they could see the pre-hospital care report, but they can actually, any patient can request their own EPCR from the agency. I'm sure each agency probably has a form that people need to sign so they can get the report, so they can actually see the report. And speaking of, I got to spend some time in St. Joe's ER over the weekend and got to see my report. I got all my lab work and everything else I could see on my phone as well. So I would assume, JH, that they probably could see their EPCR and hospital notes as well.
I think part of that too, it depends on your department, because some, I know like when it comes to like clinics or doctor's offices, it depends on your type of patient portal. So for example, like an outpatient therapy office, they don't always, or like a small office, you might not have the same note system that like a regular hospital or ER does, and you don't have the electronic capabilities to make those things so readily available. I think patients always are able to get their reports. It just might be more like, for example, if someone wants a report from District 14, we don't have a patient portal where they can sign in the way that Peace Health does. So they can come get their paper report, no problem, but they don't have that immediate access the way that you have access immediately to your notes, for example, when you go into the ER as a patient. So I'm sure it's coming our way, though. It usually tends to go that direction.
All right, so I want to touch on a couple things that Lisa brought up. And when you talk about protocols and where documentation really comes into play, and where the legal system will really, the first thing, anytime there's a lawsuit or something that is brought against the EMS system or an ambulance service, the first thing that the lawyers, well, two things the lawyers will ask for. They'll ask for your either SOPs or SOGs, and they'll ask for the EPCR, and then there'll be more information. So those are the first things that they will ask. And what we see when we look at and reviewing EPCRs in our office is I look at a lot of non-transports. And one thing that we see that's actually missing on a regular basis is the person capable of making that medical decision to not go to the hospital. And I'm going to show you, I'm going to take the screen back from you, Lisa.
Sure.
And see if I can bring up my capacity in the protocols. And does everybody see that? I hope. All right. And we've actually made a change here because one of our EMTs out at North Whatcom found we didn't have the word "not" in there. And if you read it with the word "not" in there, it would say, well, I guess they could refuse. So this is on the Hand Heavy app. Your protocols are Hand Heavy, but it's also on PPP. And so if you're not sure if the person makes or has capacity, you can just go to the capacity checklist. And if they answer these questions, then they have capacity. And this went under a lot of review. All the docs took a look at it as well. And this is what we came up with. And you can go to that in your protocols, and the same thing, you should document their capacity in the narrative. Any questions about that? All right, so let me see if I can stop the share here. Oop, there we go. Oop, gotta see, there's a question maybe. Let's see here. Oop, 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 oop. There we go. This is from, hey, Dawn. Glad you could join us. The template that fills in for the patient narrative is a little different from the recommended SOAP note for the county. Let's see, of course, my mouse is going out of control here. When you generate the narrative, is there any thinking to modify it to the standard SOAP documentation?
Yeah, so that's gonna be, well, unless, Steve, if you want to answer that, otherwise, I know for us, it's department specific. We have a District 14 SOAP that fits all of our standards, and that's what the majority of our EMTs use. So you could ask whoever's in charge of that from your department, unless there's something on the county end that's any different than that.
Oh, I guess my question would be, is there any direction from the county? I never touched that, and I would be the one to do that. And I've just had to tell my people to modify it, because when you get like down to the SOAP, the A is your assessment, and the standard template that comes in has got a lot of extra stuff that it is inappropriate. It's what you see, rule out, chest pain or whatever you're dying, but they go into a whole lot of stuff and listing patient condition and that kind of stuff. And so I honestly did not know I could modify it. I thought that was presented by the county and was to stay that way.
Yeah, Dawn, I don't know the answer to that, but I believe that each agency has an opportunity to do some modifications on certain pages or something like that. How about if you just email me that question and I'll pass it on to Diana, or email it to Diana, and then I can talk to her and we can see how that goes. I mean, I think we've never had that question asked, so I don't know, but we can try to get that answer for you.
I appreciate that. I appreciate that. And then the other thing I was wondering too, since I kind of got it, is I appreciate your emphasis, Lisa, in regards to the procedures and the medications, because that gets slipped by so many times. And I appreciate you bringing that forward, and hoping that the people here who are on board to also reinforce that back to your agencies, that that it's really important to, your example of documenting the oxygen, which way it was administered, and all those extremely important stuff. And a lot of us are missing that, just be quite blunt. We're missing that. And so the more we can bring that back to remind people, I personally would like to see it almost a little red box so you couldn't get validated, but I understand that that's not quite the thinking.
Right.
But, I appreciate you bringing it forward, because I think that's one thing that we all need to be reinforcing. And our documentation, lots of times I'm hearing about, are lacking a little bit in that area. We kind of skip over that or don't think of that. And those are important things to include. But when it does pop up, like you for a stroke or a CPR case, or those are extremely helpful as well. So thank you for reinforcing those boxes on the other side to use those as well. Thank you.
Yeah. That's where I love the timeline, because when you click on check your timeline, you can just see exactly what happened. And yeah, like with the oxygen, you can see, okay, I placed a nasal cannula, and then 1 minute later we applied 4 liters of oxygen, and it's just all in a nice line there for you. So you can really check.
Perfect.
Yeah, that is, I'm sorry, Dawn. That is a really good point, and I actually wrote that down as a note to talk about the timeline documentation. And Lisa, yes, thank you very much for bringing that forward. I mean, that is so important, because that ties into some quality improvement components for us and for the state. We do overall, we do a pretty good job of documentation in the narrative, but if you're doing a procedure and or put like nasal cannula, or you're putting a splint on, it needs to go in the timeline, and you need to, go ahead and click that arrow and fill out that form, because that's how we gather the data. And I'll give you an example, and I'll show you some of the things that we're doing in our office on a daily basis now. But let's take a look. We're all hearing about the fentanyl overdoses throughout the country and here in Whatcom County. And so we're looking at our Narcan use. And at one point we had about, I think, 30% of the Narcan use was documented in the timeline. Now, we knew that was a really low number. So what we did is we looked at the narrative, and we started to take some of the data from the narrative, which is very difficult to do, and see what our Narcan use was, and it almost jumped up to from 30 to 90%. So we're trying to stress that, and just like Lisa said, if you do a procedure, make sure you can put in the narrative if you like, that's fine, it's great, but also make sure it's in the timeline and fill out every box that's included to it. It's the same thing if you give aspirin on a chest pain call, document it in the narrative. I'm sorry, not document it in the timeline. That's how we can pull out how well we're doing that on a BLS level. When we first started to run that report, I knew we were doing much better than that. So when I started looking at narratives, I saw aspirin administered as well. Because when the medics get on the scene, they actually put aspirin prior to arrival in their timeline. Those are some things that really good points. I really appreciate it. Alyssa, another question. Go ahead.
It's actually Chief Lish here. Fast moving conversation going back to the SOAP subject and the SOAP narrative. I know Dr. Wayne, it looks like he jumped off already, but I know it is important to him that we're following that same kind of SOAP template. I know it's written in the protocols. Our reports are to be written in that kind of format, that SOAP format, but he doesn't get too specific on it. I do have some stuff done. If you want to shoot me an email, I can send you over some of the stuff that we have as far as our SOAP narrative and our report writing guidelines. But I think as long as it follows that general format, it's in the SOAP format with a subjective section, objective section, an assessment or rule out section, and then your plan section, that's going to be acceptable for Dr. Wayne. And I think you do have quite a bit of freedom to lay those out however you like, as long as it's following that format. And again, Dr. Wayne can correct that if that's not correct, but I think that was the intent, just to give a general format for everyone.
Oh, this is Dawn. Thanks, Chief. I'll do that.
Yeah,
Okay.
thanks, Chief. Actually, if you can add me to that email list, I'd love to see it too. Thank you.
Yeah, sure, no problem.
And thanks for joining us. You know, we've got a couple chiefs on the program tonight, which is very much appreciative for our system, that you see how involved our chiefs are in, and want to make sure that we're doing the right care. And I really do appreciate the chiefs being on. Talking about something that we're doing, I'm going to share my screen one more time. And this is on our website now, on the county website. So every day, we've been looking at overdoses. Well, this goes from 2021 to April, and you can see that these are all EMS dispatch calls for suspected overdoses. That could include alcohol, it could aspirin, it could Tylenol or meth or whatever it may be. But we also broke it down as, if you can see up here, I don't know how well you can see it or not, but we had over 1,400 suspected opioid incidents that were dispatched. The total suspected overdoses are 2,600, and then here's our incidents that include the opioid, which is 59 or 53.9% of our overdoses. And so this is it's a daily dashboard that'll get updated. So this is on our county website. And if you go to the EMS page and hit data, and you'll be able to go see these and take a look at that. We're looking at a whole bunch of other things regarding overdoses. It's like a county-wide initiative as well. So but these are all this data is coming from the timeline. That's how we're gaining that data. So these are just some of the things that we're doing as well.
Is that data from where there's a button where you select, is this an opioid related incident? You can either select yes or no. Is that where you get that from, or is it from dispatch information?
No, we're actually, you can check, when you check that box or when you click that box, yeah, we're getting that information now too. Yes, off the EPCR.
Okay.
I was hoping Diana was going to join us, but because she could talk more to this than I can, but she's doing this every day for us as well. So these are just some things that we're doing as well. And of course, if you join us at our CQI meetings, you can hear some of the other reports that the CQI committee, which Dawn and Dr. Wayne have led for the last year or so as well. Anybody else have any other questions? Sam?
Yeah, so I was curious about like for continuation of care, for hospital care, that sort of thing, just as the reports are viewed, what's the best way to document like I don't know what to call it, semi-known medications, or medical history, but mostly medications. So you have a patient, I don't know, traumatic call, and there's an RP who says, I know they're on blood thinners. I don't know what blood thinners they're on. Like, what's the appropriate way to document unknown blood thinner? Or I don't know. Somebody said, oh, they're on insulin. You don't know what variety of insulin, but they're on insulin, or that sort of thing. What's the appropriate way to document those semi-known medications?
Steve, you want me to answer that?
Yeah, go ahead. Go ahead, Lisa. Yeah, go ahead.
Yeah, so on your image trend, there's where you put in your medications. When it's a known medication, you can just select it from the list. And then below that is that empty box where you can document. You can write patient is possibly on a blood thinner. And then below that, it gives you the option to select who gave you the information. So you can say patient's family member, or patient's, or, witness on scene said they saw, this medication on board or whatever. So you can put that all underneath your medication list. And then you can also write that in your narrative. And then obviously, if you have a chance to talk to the receiving facility RN, you can say, hey, they're on a blood thinner, we're not sure which one. And then seems like most of the time our patients already have a record at Peace Health of some sort. So they usually have that medication already in their system. But from our end, we can just put in that the person who you got the information from stated that patient was on a blood thinner or a hypertensive medication, and then that's all you can really do.
Thank you very much. Just while I've got it, in the brain, is there a similar option for medical history? Somebody says, I know they had a surgery, I don't know what for.
Yeah. Are you familiar with Image Trend, or would you prefer that I can pull up Image Trend? Getting this.
I'm sorry. Could you say that again?
Yeah, no problem. Are you familiar with Image Trend, like where you're inputting that information? Otherwise, I can screen show you.
Yeah, I am.
Okay. Otherwise, same deal. It's you have that spot where you can select like the pre of medical issues, and then if you're not sure, you can just type it in that box below, and then that will be included. Like when you do make that PDF version of your care report, it should be in there underneath your official list of meds. You can have that. The things that the patient stated or that the family member stated that you're not 100% on.
No, thank you very much.
Yeah, no problem.
You can also, put it in the narrative as well. Reporting party states has a history as well. You put it in a couple places just in case. It can't hurt. All right. All right. Any other questions for Lisa, or any questions that we can try to answer for you about the system, or anything I can try to answer for you? All right, not hearing none. I think everybody should just give Lisa a big hand, because I'm going to give her a big hand and say thank you very much for doing this for us. And thank you for joining us, and enjoy the rest of your Thursday evening.
Thank you, Lisa. Good night,
Hey,
everybody.
thanks, Lise.
Yep, thank you.
Thank you very much.
Thanks, Steve, as well.
Thanks, Chief. Nice job, Lisa. Nice job.
Thank you.
Yeah. Hey, do you think we can, if you don't mind, if you send me that PowerPoint, I'd love to put it up on Rescue Hub for people to take a look at.
Didn't have much on it, but I can definitely send it to you.
No, you know something?
I really like PowerPoints where you read everything the person's gonna say, because then there's
Yeah.
no fun in it.
Yeah. Oh, yeah. You did it great. I mean, because you see, I'm sure I'm sure you sat through a whole bunch of PowerPoint presentations where people say, well, A, B, C, and then there's D, E, F right off the slide. No, it was perfect. But no, I think I'd love to put it up on Rescue Hub and just as a resource for people to take a look at and give people ideas. It's fantastic. You hit the high spots. I mean, it was just fantastic. You hit everything that I want us to get out into the system and try to improve some of our documentation. The timeline part is where we're really hurting. And then of course, refusals are always difficult, but you hit both those top points that I would have made as well. But I'm so happy you did this. So thank you.
Yeah, glad it worked out this time.
Yeah, me too.
Took something away from it, then we're all good.
Yeah. Well, say hi to the kids, say hi to your husband for me.
Yeah, will do. Thank you.
Thanks. Bye-bye.